Hello, everyone. We are actually holding another roundtable of discussions regarding the GU ASCO updates and in general, the ASCO updates in prostate cancer for the past few months. And I think that eCancer has become a home to very nice and very exciting discussions. And we're always joined by rock stars in the field. So today, our title is a little bit more sexy. It's about the promise of personalized medicine for patients with prostate cancer. And I'm joined by people you know so well, Dr. Morgans, Dr. Attard, and Dr. Fizazi. I couldn't understand who I should go first with when it came to the gentleman. Of course, I went for the lady first. And we kind of prepared a little bit how we're going to go about it. Given that some of us are already involved in a lot of the trials that were discussed, we're trying to put on our independent hat, of course. As you know, we've got quite a bit of disclosures, but that I think gives us more the opportunity to understand what's going on and give you like the inside view of things. And then those of us who are not participating in those trials are going to give the, how we see it from the outside. So without any delay, I'm going to turn to Alicia, and she's going to wow us about what happened during this last GU ASCO. It's going to make a difference with what? Androgen signaling inhibition. It's kind of an oxymoron because we're so used to using the enhanced androgen signaling inhibitors. But Alicia, your take-home messages.
Great. Well, thank you. Even though we've been investigating androgen receptor targeted therapies for well over a decade now and have been intensifying for a long time, there are still updates and things to learn. And certainly there were some high profile presentations at GU ASCO focused on this. The Titan study update was presented, and this was a 4-year median follow-up for patients who had metastatic hormone-sensitive or castrate-sensitive prostate cancer who were treated with ADT with or without apalutamide. And we saw that this clearly demonstrated a continued overall survival benefit related to that combination of ADT plus apalutamide in the metastatic hormone-sensitive setting. Quality of life was maintained, and really across subgroups, there was a maintained and continued benefit. So this combination, this intensified strategy seems to hold up quite well, as we would expect, and that was the update there from Titan. We also...
I'm going to stop you there for a minute and jump into Dr. Fizazi. Karim, I know you've been so involved with the development of darolutamide, the newcomer. We're all anxious to get the data that's going to come out of the trial, the phase 3 with darolutamide. It's the only one that hasn't reported. How soon should we expect them? What do you think? I know you can't tell us exactly, but where are we?
Right. Well, I can tell that the accrual is completed and that obviously events are coming. So I think we should see the data, say not in a too long future, so maybe this year or the next year. And you're right, this is the purest trial testing darolutamide on top of ADT plus docetaxel. There are 2 other trials looking at this question with enzalutamide or abiraterone, namely Enzamet and PIS1. And I also think that we will see data from these 2 other trials, perhaps this year. So let's say that maybe in a year from now, we should have a much better overview about whether 3 drugs is better than just 2 in men with M1 disease.
So you said it, that's going to be the big difference, because till now we've been looking at ADT plus 1 mainly, even though Titan did have a few that had received first Dossi, then went on, and Enza-P did too, but Enzamet, sorry. But Gert, you've also promised we're going to see something from Stampede coming soon through your trial.
The comparison from Stampede, which hasn't reported, is the combination of abiraterone with enzalutamide plus ADT, of course, versus ADT. And therefore, to ask the question about benefit over Abi plus ADT or Enzo plus ADT, an indirect meta-analysis approach will be required. Given the significant benefit with Abi or Enza alone, hazard ratios 0.63, 0.6, I suspect we will not have enough power to conclusively show a benefit for Abi plus Enza plus ADT versus either alone. But let's wait and see. And I guess it's all the more pertinent given the results from ACES.
Gert, I like your approach. It's like you're preparing us for the worst so that we can be happy with what we get. I mean, really, that's a nice way to go. But no, joking aside, really, it's like the movie. When you say too many good things, then everyone's disappointed. So that brings me to the first trial that actually reporting positive. And both Gert and I have been really heavily involved. ACES in CRPC, Alicia, back to you and get your thoughts on that first positive trial and how you view those results in mCRPC, of course, not hormone A.
Yeah, I think, so this was a really interesting trial because these patients in the first line mCRPC setting had not received an intensified strategy in the metastatic hormone sensitive setting. So they couldn't have had an AR targeted agent or docetaxel when they entered into this first line mCRPC ACES trial. In the study, then they were randomized to Abi plus apalutamide or Abi alone, and they were followed for a primary endpoint of radiographic progression-free survival. Overall survival was a secondary endpoint. There were quality of life assessments. So what we saw in this study was, as you said, the primary endpoint of radiographic progression-free survival was longer in the combination arm of Abi plus apalutamide by about 6 months. And what I found most compelling about this was that this was investigator-assessed radiographic progression-free survival for the primary endpoint for the study, but they did actually do a retrospective central review of the radiographic progression and found a high concordance and a consistent positive endpoint there with that central review of the radiographic progression. So that seemed to be a quite durable endpoint, was quite strong. There was a slightly higher rate of adverse event by the CTE-CAE criteria, but although there was a slightly better quality of life for the abiraterone arm by patient report in the beginning, as the study went on and throughout the study generally, if we look at it overall, there were no real differences in patient-reported quality of life between the intensified arm and the single drug arm, which is important too, because if you're going to intensify but people feel a lot worse, that's definitely something that you have to consider, whether you're in clinical practice or in clinical trials. That can make a big difference when we're making the decision to intensify. So it was positive, but with caveats.
So I was gonna get to that. And I want you were very honest. The whole idea of making positive and important, I believe it was, over 7 months at the end of the day, the final analysis, the difference is also to get a better quality of life. And sometimes the tools that we use are not the best and what have you. But in your opinion, the fact that if I understood that correct, you're saying that the fact that we didn't see yet in the secondary endpoints, that difference kind of takes a little bit away, forget the OS for a minute, takes a little bit away from that RPFS. Is that right?
Well, I would say not necessarily, because I do think if you're not making people feel worse, you're actually maintaining quality of life and prolonging progression. That's a good thing. What I think took the wind out of some people's sails related to this is that the overall survival for the trial, so secondary endpoint, not powered for that, was not significantly different. And I think that's what took a little wind out. But the other piece is that in the United States, at least, when we have to get both of these drugs, there's going to be potential financial toxicity that was not that wasn't recorded in the trial. It's not something that we can measure when drugs are provided for free. And so that is the other, I think, barrier that people think about when they're thinking about the combination strategy. But I think if you have a better outcome and you're not making people feel worse, that's still a win on some levels.
Okay, I'm going to take the European Union opinion by Dr. Fizazi. I'm making it, very formal. And then the ex-European Union, UK opinion from Dr. Attard. Do you think there's a future in these combinations? Because it's like we're looking again at the docetaxel plus, but this time we got a positive trial, regardless of comment. Karim.
I actually quite agree with what was just said by Alicia. At the end of the day, as doctors and probably as patients, what we want is a treatment or treatments that can either prolong our life or make your life easier, basically. And RPFS is something we're using because the agency like it or kind of like it for approval when we are not necessarily able to show overall survival improvement. But basically, in the practice, nobody really cares about rPFS. I'm not measuring rPFS in my routine practice, and I'm pretty sure that you are not, and patients don't really care about it. We're not necessarily counting the metastasis. So I think that it's okay if a trial has a primary endpoint of rPFS, because this is mandatory for approval reasons, and because this is an objective thing, basically, but it has to show something on top of. And on top could be, of course, overall survival, but also pain control or better quality of life, lower cost. I mean, different very important things to patients in the society. And here, this is not an example where we do see something on top of rPFS. So I don't think that this will fly due to that. Now, having said that, I think that it's still showing us, scientifically speaking, that the AR axis remains very key in this disease, and that perhaps with super abiraterone or super enzalutamide or apalutamide or whatever, we may be able, to show more meaningful benefit to the patient. Basically, ABI and APA very probably, like API or ABI-ONZA, share pretty much the same mechanism of resistance, at least part of them. So the incremental benefit of APA on top of ABI is there, but it's not super big. Now, if ever we are able to invent other drugs that better target the AR axis when basically their cells are able to resist to the current generation of agents, then we can really make a difference. And probably this is what ACIS is suggesting, basically.
So thank you for that. You can be also provocative at times, as I saw nobody counts rPFS. You said nobody. So that was actually, to a significant degree, the reality. I was just thinking when you said that what becomes important is the peace of mind that you have a patient who is not experiencing serious progression events. But it seems that these trials are not looking as much at skeletal-related events because we're early in the disease. But I'm going to take it to Gert for one comment in the interest of time on, you're left now to defend ACIS, of course. And I truly believe and agree, and I've said it multiple times, we have to figure out subsets of patients who will get a benefit from the combo. But you're also the person who presented Plato trial as a big trial in sequencing, and you're the person who prepared us for the next step in hormone naive. Gert, your thoughts, your wisdom on that. Where are we going?
I agree with Karim. I think what excites me the most is the potential biological message that blocking both androgen synthesis and AR antagonism appears more effective than blocking androgen synthesis alone. Now, potentially that when you use ABI alone, you salvage with subsequent AR antagonism. The trial's not going to tell us that. We don't have the power. But I find that biological message very intriguing. And hopefully that will translate into a much bigger benefit when started with ADT.
So it could be that those feedbacks that we had reported from MD Anderson a while back might be a little bit true, but may not really relate as much to across the board. So we'll wait for more from you, Gert. Back to you for one comment, Alicia. Finally, we are getting a transition to even earlier in that high-risk phase, which for the United States and Europe and UK is an important unmet need, with 70% of men being at risk of recurrent. Are we getting anywhere? What was the prospect within GU ASCO?
So there was a nice trial in progress presented. Dazzle HiCap is a study where we're trying to intensify androgen suppression, both in the primary radiation setting, where we're using combination of androgen deprivation, in addition to radiation, of course, and in the post-prostatectomy patient population that's so high risk that they still have a detectable PSA post-prostatectomy. And in this study, they're using darolutamide to do that extra extra little kick of androgen suppression to see if that intensification can make a difference. And that trial's in process, and we will see, but it might be another trial from the ANZUP group and from Chris Sweeney that ultimately ends up changing our practice. We will see.
Karim, your thoughts. You're the darolutamide, I don't know, master PI. Tell us about it.
I guess regardless of the drug, I think that really, I strongly believe that the concept will fly indeed, and that eventually, and probably not in a far future, we will be using next generation hormonal agents in high-risk localized disease. Actually, I think that Gert and his group in the UK and in Switzerland will really lead the charge thanks to Stampede. And I think that abiraterone data, because as you know, there was an abiraterone arm in Stampede, and including some patients with high-risk localized disease. I guess the data will make sure, maybe, I don't know if Gert can comment on that, maybe this year, maybe in the coming years. And if I have to bet something, I would bet quite a lot on abiraterone showing metastasis-free survival and perhaps overall survival in the setting of high-risk localized disease. So I think this will very likely be the future for patients. And then there will be, of course, questions around how long we should use these agents, the balance between the likely benefit and the toxicity, of course, also the cost for the society. Let's say that if it's abiraterone, this will be a generic drug as opposed to enzalutamide, apalutamide, darolutamide, which are not. So all, I guess, these questions will apply. But I strongly think that indeed these drugs will move in the space.
Well, thank you very much. And again, I mean, we can't give enough of thanks to the Stampede folks for starting all this and making a difference. But you just said something about the future. And, you know, it's been very elusive when it comes to immunotherapy in prostate cancer. So we're going to move on to immunotherapy and where we stand. We're not there yet, we know, but what did you, from your experience in the trials and what was reported during this GU ASCO, go away with? Do you think we're closer to identifying the subsets or enhancing somehow the impact?
Right, you're very right. It's surely something quite terrible, the history of immunotherapy in this disease, because we basically know that some patients clearly benefit, sometimes fantastically, with appearance of cures of metastatic disease, like a decade after that. I do have those patients, and that was reported. But on the other hand, we haven't been able to show this a meaningful way. What we saw, I guess, at this GU ASCO included data testing IOs in men with even neuroendocrine differentiation and or what are called aggressive variants. Very small trials, very negative. The hypothesis made sense. You might hypothesize that indeed these crazy aggressive cancers might be associated with a bunch of new antigens, so that IO might work, but actually it doesn't seem to be the case. Actually, probably the only patients who benefited had an MSI high cancer. Having said that, it was a mixed bag of mostly aggressive variants, 10 patients, and only 5 patients with neuroendocrine differentiations. So we may have missed the signal. At least I think we need to be cautious when it's really a small group of men. But it's negative. Now, in parallel to that, two phase 2 trials tested IOs, nivolumab in one and pembro in the other one, together with chemotherapy, with the docetaxel chemo. And here, of course, the data look good, if you will, because there is efficacy. But to be honest, even if I was deeply involved in one of the 2 trials, it's really hard to say whether we're doing better as compared to what we would have seen with the docetaxel alone. Even in a population of men pretreated with abiraterone or enzalutamide, the docetaxel works. And what we saw was pretty much a 40% response rate, even by RECIST, and say 8 months plus progression-free survival. So it's probably in the highest rate of what you would expect with the docetaxel alone, but whether it's truly different, I'm not really sure. Based on those data, the two companies made the decision to start big phase 3 agnostic trials, so without selection on molecular grounds, which I don't really like, to be honest, but I can understand the industrial decision, if you will. So we'll see eventually whether there is a benefit, but I think more and more for immunotherapy, we should design a trial in subset populations of patients and test a given hypothesis. I think this makes much more sense to me.
Well, it's going to have to end up to be investigator-initiated big groups like Stampede and the like that are going to push the agenda. Having said that, you guys know better than I that they're designing these big phase 3 trials from the standpoint that they've got approved agents on the market already. So there's not a lot of risk for pharma, unlike what has been the case for other agents, such as satraplatin, for example, that we were discussing, that lost it. So, and other trials. And in the interest of time, I'd like to get a comment from you, Gerd, on what is the future of immunotherapy, especially when we see trials being transitioned to hormone-naive space, such as the Keynote, without even having the robust data that Karim alluded to. But then I want you to go into what must have been the most sexy presentation for the second time in a big meeting, and that's of course the data that we have on theranostics, lutetium, PSMA, and where we're going with that. So, floor is yours.
So I agree entirely with Karim. I have my reservations on treatment of unselected patients with IO, given the very clear response rate is less than 30%. So I think enough said on that. I think it's even trickier to interpret when introducing these therapies at start of ADT. But time will tell. And if nothing else, there's a small group of patients who could benefit from that treatment if given the opportunity to take part in that trial. So moving on, this is a precision medicine session. Beautiful work by Michael Hoffman and Peter Mack in Melbourne. And that follows on from there. I think it was the first prospective phase 2 trial of lutetium PSMA. And is the follow-on asking the question about best treatment in patients progressing on docetaxel. And more than 90% had also received an AR targeting therapy. And about 200 men were randomized between cabazitaxel after progression on docetaxel or PSMA lutetium. They screened, I think it was 280. And the devil will be in the detail, and this will become very interesting. But clearly they have a robust or a biomarker that's been well thought through. Their eligibility requires PSMA positive disease, 20 or more at one site and more than 10 at the other, with no discordance with FDG PET. And that's interesting. So I don't think Vision, for example, has used FDG PET. Bottom line, the trial used decline in PSA as its primary endpoint and is positive. So a higher response rate with PSMA lutetium versus cabazitaxel. And of course, that's not an endpoint for regulatory submission, and we'll need to await the results of the Vision trial, which was powered for OS and I think RPFS. So they were co-primary endpoints. I know Karim was involved in that.
So I wanted to go to Alicia, but for me, when they presented, the most important was that little table that showed that 20% of men who got exposed to this treatment remained progression-free for 12 months versus 3% with cabazitaxel. And I'll be honest, I'm one of those people who will re-challenge with cabazitaxel after 6 months and do it again and over. And you know, I'm very comfortable with the safety profile. But I want to take it to you, Alicia. I know it's very late stage disease. I want to get your thoughts from yours looking at the safety profile and with that prospect of getting men who will be treated and not potentially need a treatment for a long period of time. Do you think that is a very important prospect? I know 20% doesn't sound like a lot, but we expect that it will transcend to a bigger percentage earlier in the disease. What are your thoughts?
So I actually think 20% sounds like a lot. That's 1 in 5 men who would be progressing. And if I were in that group, I would be very, very happy. And we all have these men who, especially at this state of the disease, are looking at feeling really poorly as each day goes by because of the complications of the cancer. And certainly if we can put those off, I think that's a win. I think, the toxicity data also suggested that this lutetium was very, very well tolerated. And really the AE data suggested that it was at least as tolerable as cabazitaxel, and the patient-reported outcome data suggested at least as tolerable as cabazitaxel, though there was less of a difference there. There were definitely domains where the lutetium seemed to win, like social functioning and some others that might be a little bit more impaired by cabazitaxel. I use a lot of cabazitaxel. And so I agree with you. I feel comfortable with that drug. But I think when we have a new agent that might maintain quality of life and make 1 in 5 people potentially not require further additional therapy at 12 months, that's pretty big.
Karim, yeah, I mean, again, exactly like Alicia says, I have a patient I've literally re-challenged 7 times with cabazitaxel, and he responded each time. Now he's not anymore, and I don't have lutetium. Is vision going to be a big game changer? What do you think?
Well, I guess we'll know very soon.
There you go again, being a sphinx. Just
no. What I would say also is that I think we all agreed that cabazitaxel remains a good drug, and even if the Australian trial suggests that indeed lutetium PSMA has in that setting and in a very selected population of men based on PET and double PET, perhaps better safety efficacy balance than cabazitaxel, I think we will probably keep using these 2 agents sequentially. My gut feeling, and I hope we'll have soon more data, is that one drug can perhaps circumvent resistance to the other one, which is not true for all drugs. We discussed already abiraterone and enzalutamide, and that could be really fantastic for the patients if it is the case. I share what you basically said. Well, first, cabazitaxel usually is not very toxic, especially with a 20 milligrams dosing, and if you're using GCSF. That's really manageable toxicity as compared to many other anti-cancer drugs we're using. Second, there are some patients with really fantastic taxane sensitivity. We all have them when we recycle, etc., for years sometimes. So it's really great to have taxane for these patients, especially cabazitaxel, because we don't see the cumulative toxicity that we used to see with docetaxel. Now, on the other hand, yes, indeed, I think it's really fantastic to see a very likely newcomer with PSMA lutetium, quite non-toxic in general, and quite active. Maybe 1 or 2 caveats, though, regarding the toxicity. One is about long-term hematological toxicity, and Vision will probably tell about this. I saw some patients that required really transfusions again and again for platelets or for red cells, and it was getting rarer to see this in my mCRPC experience. So let's see if it's a true finding or just bad luck. And the second caveat is if ever Vision is positive, and if we move or try to move it in a clinical trial context, a PSMA lutetium early in the course of a disease, there's always a risk for second cancers or myelodysplasia. So we need to be extremely cautious regarding this aspect before we make it ready for prime time.
This is an excellent point because, personalized medicine is a combination of things, and we're dealing with older men. So once you're going to laugh, but a urologist told me, your personalized medicine starts in your clinic. It's absolutely right. It's that man that we're talking to. It doesn't have to do only with the targeted therapy or this or that. It has to do with everything this man is about. But having said that, education for us, the healthcare providers, becomes very important. And Gert, I'm going to take it back to you. We've come to the era where we're actually are inclusive of targeted therapies in prostate cancer. So we're not as behind as other cancers, but it's taking a while. And tell us what you saw and what your take-home message is from this GU ASCO with that in mind, from the perspective of more precision medicine-driven therapies.
So I guess the most compelling data continues to relate to detection of DRD mutations, and specifically BRCA. We saw breakdowns of response rates by gene type in the PROfound trial. The high response rate maintained in BRCA2. I think big questions remain on ATM. And we're seeing that plasma is concordant with the original tissue sample in about 75% of patients in that trial. Of course, that proportion will be dependent on tumor volume, how much tumor is circulating in that patient. Of course, it has to be above a certain level for detection. And then the other very interesting area is AKT inhibition. With the trial in CRPC, the hypertension 150. And for both these approaches, at GU ASCO, we saw trial in progress abstracts taking these approaches earlier. So the Amplitude trial testing niraparib, Abi plus ADT versus Abi in men starting ADT, M1 men, and the Capitello trial that Karim's the PI for testing cabazitaxel. Plus, I think it's Abi versus Abi in men starting ADT.
So it seems that we're understanding more and more the importance of assessing the presence or not of DDR mutations, and we're still trying to find a place for other targeted therapies. We don't have yet an approval for targeting PTEN loss and PI3 kinase pathway. And my personal impression is that we might need to go earlier in the disease beyond everything. But Gert, you pointed to the importance of actually kind of nailing the right assays. And that's going to be a big part of it. It's tedious, but it's going to be a huge part of it. And we're not there. Yesterday I was on a telemedicine with a European patient who was like, this lab gave me a report of some mutations, and should we act on it? It's a patient who's been through everything. And I'm like trying to be nice and say, maybe in the future we'll have confirmation of use. But it seems that there's now a plethora of such assays that have not been validated. And we need to be really careful. We're all privileged to be in big institutions, and I'm talking more to the people who are listening to us who are smaller. So we've got to be a little bit skeptical, it sounds like. So I would like to finish this discussion by thanking you all for your wisdom. I keep learning from listening to you. And I do hope that in this coming ESMO, or ASCO, I'm going to say too, we're going to have more data that's going to get us closer to having personalized medicine. Thank you all very much.